Hi guys, Talisha from P3 here. It's been a minute, it's good to be back, thanks for your patience. And the reason that it's been a little bit of a minute in between podcast or vlog episodes is we've been working really hard behind the scenes on getting a few more projects up and running. And the first one, which has just gone live, is our new online mentorship, which is commencing the first week of December 2022, called Private Practice Prepared. So this 10-week or 10-session online mentorship is designed for upcoming graduates and also people that have entered podiatric or physiotherapy practice in the last, say, 5 years. So in this mentorship, we're covering a huge amount of information, and a lot of this is relevant to your clinical practice, regardless of if you've been working or are going to be working with general client populations, even to elite sporting athletes. So we're covering client communication, footwear prescriptions, orthoses prescriptions, exercise prescription, therapeutic goal setting, and so much more. So if you'd like more information on this, head to progressivepodiatryproject.com/prepared. And now we'll get into today's episode. The Progressive Podiatry Project, here to share knowledge, insights and information for you to improve your clinical practice and, most importantly, help you help your clients. So what we're covering today is if you deal with patients that have chronic and or complex musculoskeletal presentations and you're finding that you're oftentimes falling short of reaching your and your client's outcome goals, it may be a capacity problem. Now, as we know, musculoskeletal pathologies develop as a result of an imbalance in the load-capacity equation. But what we can oftentimes forget is that load isn't always physical. We do have psychological load, and standing reason to this, we have psychological capacity as well. So if we're failing to address the psychological load-capacity equation in these chronic and complex presentations, this may be a missing piece of the puzzle, so we'll get into that now and let's unpack. Now, as we know, everyone's load tolerating capacity is different. My load tolerating capacity compared to your load tolerating capacity, both physically and psychologically, are going to differ. So we need to be considerate of this and understand all of the different elements that feed into this load tolerating capacity. So when we're talking about the chronic and complex patient, a few keys that might give you a bit of a hint if you are dealing with someone that's got a little bit more of an issue when it comes to their psychological load tolerating capacity is if you've often had these thoughts or these situations have arisen where you may find that you're in a consultation and you're trying to explain the pathology to your client or patient, and you can see that they're not really understanding, or they're getting frustrated, or they're just coming back at you with a lot of rebuttal or rebuke as far as not taking what you're saying on board. So that's one situation. Now, another few things might happen is if you're finding that your client's not engaging or adhering to the treatment plan that you've put in place, or you're just finding that you can't get on the same page regardless of if it's the exercise interventions or other health-related behaviours that you're trying to implement and evoke this change with them. One of the other things that might give a little bit of a hint if it's more a psychological load capacity equation problem is if we're having that sort of presentation that's more consistent with the chronic pain, where the pain doesn't necessarily marry up to the physical presentation that you're seeing. So what is capacity in the context of physical rehabilitation? In its simplest form, capacity is the amount of load that a tissue, structure, or person can tolerate. Now, if we exceed the load tolerating capacity of the tissue, the structure, or the person, adverse events such as injuries or pain flares can occur. So where, again, clinicians can often sell themselves short is failing to recognise that capacity and loads are both physical and psychological. So if we're talking about physical load, it's the physical loads that are being applied. So, for example, this may be the cyclic loading of a tendon during running, or the eccentric load that the gastrocsoleus muscle tendon unit complex undergoes when we're landing from a jumping task. Now, if we look at psychological capacity, there's a few things that feed into this. So for one, we have our allostatic load, which is essentially the cumulative burden of chronic injury, stress, or illness. And then we also have other factors that feed into psychological load. So we've got cognitive load. That's something that's been explored to some extent, but we're not going to go too far into that today. And another key factor or element that make up our psychological load and tolerating capacity is the psychobehavioral traits or yellow flags, which we have discussed in depth, and I do cover it quite in depth in the online course. So yellow flags are a huge key player in this space because, as we know, the presence of yellow flags in musculoskeletal pathologies are very highly predictive of poor treatment outcomes if they're present and they're not addressed. Now, just to make it probably a little bit clearer and easier to understand the importance of psychological load and psychological capacity is one of the quotes from Lorimer Moseley, which I'll probably end up paraphrasing because I'm not great at quoting just off the top of my head. But essentially one of my most favourite quotes of his is where he's said that the relationship between pain and the state of tissues becomes weaker the longer the pain persists, which essentially means that, yes, we still may have someone in pain, but the longer that pain has been present for or persisted for in relation to the time when an injury occurred, the less the pain often has to do with local tissue factors, and it can have a lot more to do with psychological and or psychobehavioral elements. So what this may look like in clinical practice, we'll use an example of plantar heel pain because this is one that many podiatrists and physiotherapists will see almost on a daily basis. So if we picture, we may have someone, so let's just say our load tolerating capacity is 100% because that's what it actually is. Now, for one person presenting with plantar heel pain, 80% of their presentation may be due to physical loads that we need to address, and then there may be 10% might be psychological loads that are driving some of their pain presentations. On the flip side, we may have someone who's got plantar heel pain and 80 or 90% of their pain and pain presentation may be driven from psychological factors, not so much physical factors. Now, keeping this in mind, if we have these two differing presentations, but we're applying the exact same approach and treatment intervention, it may very well address one person's presentation, but it can very much sell the other person short as far as addressing what's actually driving their pain and helping them achieve a positive treatment outcome. So what this may look like, if we have someone, say it's the more psychological driven plantar heel pain presentation, they may be experiencing a lot of pain-related anxiety and fear avoidance and kinesiophobia. And then for the purely physical load tolerating capacity equation, on the other hand, they may simply just have done too much. They may have some local tissue adaptations or maladaptations in response to loading. So there's maybe a very sort of simple equation of calming things down and building things up as far as the type 1 collagen of the plantar fascia goes. But if we're applying the exact same treatment intervention, so let's just say we skip the educational part, the reassurance part, the building rapport, which unfortunately does happen in clinical practice where there's little time given to the actual getting to know someone and exploring their specific drivers of their presentation and going straight into a treatment intervention. Now, I'm not saying that everyone does this, but I think we all know that it is still fairly common in clinical practice where clinicians can be still very much treatment or pathology focused as opposed to person-centered or person-focused care. Now, what this may look like is if the person comes in, they sit down, they describe their symptoms, and we go, yep, no worries, it's been a whole of 5 minutes. We go straight into dry needling or shockwave or recommending orthoses or a gait assessment. So for the person where it's a purely physical or mostly a physical load capacity equation problem that we're dealing with, that may be okay. Now, I'm not going to get into the arguments of best practice guidelines for plantar heel pain or anything like that. This is just an example because it's an example I think a lot of you can relate to because you would have seen this happen in clinical practice or you may be doing this in clinical practice. Either way, not going to unpack that. It's just an example. Now, If we apply that approach to someone who's got a lot of this movement or pain-related anxiety and they're kinesiophobic, so they're scared to do certain movements because they have this fear it's going to cause more pain for them or cause more tissue damage, if we're going straight into these interventions and not unpacking their fears and what's triggering their anxiety and helping formulate our management plans based on their psychological needs and helping them build their psychological capacity to understand what's going on and help overcome their problem and build their psychological capacity, this is where we can be selling them short. Now, expanding on this a little bit more, if we have someone where their primary driver is psychological and or from psychobehavioral factors, what we may find is actually spending more time giving them some reassurance, compassion, educating them and help coach towards more positive health-related beliefs and or health-related behaviours may be more impactful for them and helping them achieve a positive treatment outcome, as opposed to focusing on a specific exercise intervention or orthomechanical intervention or electrotherapeutic intervention. Now, I did mention a few of the yellow flags just before, where we have our pain catastrophization, kinesiophobia, and pain-related anxiety, but there are a few other psychobehavioral mechanisms or presentations that we may see or may drive these presentations. So some of these are a person's health-related beliefs or their beliefs about pain, their beliefs about movement. That can play into the psychobehavioral presentations. We also have a person's locus of control. So if someone has a high internal locus of control, they do feel that they themselves have the ability to at least partially control what's happening to them and around them. Where if we've got someone who's got a higher external locus of control, these are often the patients that you'll see that come in and it's very much like, I'm here for you to fix me, not can you help me build the tools and build the strategies to let my body fix itself, if that makes sense. As I mentioned, there is kinesiophobia, there is pain catastrophizing, there is anxiety related to pain and or movement, but we also have self-efficacy that plays into it as well, coping strategies, and even familial factors and cultural factors. Because one thing I did find, especially when I was working in the workers' compensation space, because that was very different to clinical practice in the sense that oftentimes when we're working in clinical practice, we'll often see a more common demographic. It's often not as diverse in the presentations that we see. When I was working in workers' compensation, you had no choice as far as who or what was going to come across your desk when you were going to be managing an injury. So you may have someone from a farmer out in the sticks, or it may be someone from a non-English speaking background. And one thing that I did find, and it's pretty well documented sort of across the scope of yellow flags and chronic injuries, there are certain cultures that their beliefs around pain and their beliefs around injury are quite significantly different to other cultures. But anyway, that's for another day. But just wanted to highlight or give you a bit more of an idea of what some of the other psychobehavioral elements that we may be dealing with that builds into someone's psychological load tolerating capacity equation. And talking a bit more about the load tolerating capacity equation, as I mentioned at the start of this episode, we do have our psychological and or our physical loads that will, one, contribute to the presentation or initiation of a pathology. But then if we also have a flare of the injury or a flare of pain, the flare drivers for physical or psychological will be different. So a flare driver for a physical injury may be, or if we're talking about plantar heel pain, it may be having an increased time on feet or a increase in running mileage, or it may be a decrease in time between load exposures. So essentially just a significant change in physical activity and physical applied loads. Now, if we're looking at psychological capacity, some of the things that can be our pain or flare drivers in that realm, it may be poor sleep, it may be an increase in work stress, it may be an increase in home stress. And you will often find people, especially with these chronic presentations, they will have a little bit of both going on. But it's very important when you have someone coming in, and if it's the first time you've met them or it's someone you've been seeing for a while, it doesn't matter. If they are experiencing a flare, asking questions relating to what physical loads they've been doing recently, but also what psychological loads may have been increased or may have altered. So has there been anything going on at home, and has there been any changes in your work schedule or the environment at work? So it's up to you to figure out how to phrase these and read the room with your patients and not cross the line. So doing it diplomatically, but that's something that we do with practice. This is just trying to paint you a bit of a picture on the two different elements that we need to consider and also need to explore, and some of the elements that you may need to explore to identify what the driver is. Because again, if we identify what the driver is, this will dictate what our management approach will be. So when it comes to building physical and or psychological capacity, either way, that's our primary focus as a clinician, because someone's come in and whatever the presentation is, it's stopping them from being able to engage in an activity they want to do or multiple activities that they want to do, and the presentation's essentially becoming disruptive to their life. So what we want to do is build their capacity so they are able to re-engage in those activities, regardless of if it's psychological or physical. Now, both of them will overlap, especially in these chronic presentations. So the two examples I used earlier, there may be someone that's got 80% driven by psychological factors, 20% by physical, and then on the flip side, we may have someone that's 80% driven by physical factors, 20% by psychological factors. So regardless of that, you will find that people have a little bit of an overlap. It's just identifying the primary driver. Now, if we have someone that it's more psychologically or psychobehaviorally dominant for their presentation, oftentimes helping them build their capacity is where we sort of lean on our soft skills and more of the therapeutic alliance that we create with our patients. So some of the ways that we can help build this psychological capacity is by paying attention to our nonverbal communication, using responsive or reflective listening, helping them understand their body, their pathology, and helping normalize somatic sensations. So pain is real, it's a protective thing, it's not bad that it's there, it's just a little bit disruptive to your life right now. So we're going to look at ways that we can try and dampen down that hypervigilance state that your body or your nervous system's in. Anyway, a few other things that help with us being able to improve someone's psychological load tolerating capacity, which also leads to them building their physical capacity, is goal setting. And then another thing is that's very, very important, and I have spoken on this in previous episodes, is dosing exercises to their tolerance. So this is where instead of following like a pre-scripted, you're going to do 3 sets of 15 repetitions for this exercise, because for someone that's experiencing a pain flare, if they're trying to sort of push through the pain, they may be driving themselves further into a flare because they're just exceeding that capacity that they've got. But on the flip side, what we can do is we can use the visual analog scale of pain to dose our exercises. So this is the traffic light system that I've spoken to previously. So regardless of if you're listening to this on podcasts or it's on the YouTube channel, wherever you're listening to it, because it's spat out across quite a few different platforms, we do have that video that is how to dose exercises in the presence of pain, and it goes through the traffic light system and how you can use the VASP to help people, one, understand their body, but two, help them dose their exercises so they can continue moving, continue getting positive adaptations, but not driving themselves into a pain flare. It can actually help decrease the pain flare and shorten the duration of it. And another benefit to doing this is by doing that, it helps build their body awareness. So the more someone's aware of their body in a positive way, not in a hypervigilant, everything's going to hurt me way, this is another way that we help build their psychological load tolerating capacity. So let's imagine that we've had a really good conversation with the patient that's presenting to us, and we've been able to identify what their pain driver is or what their flare driver of pain is. And we'll use the 2 examples of plantar heel pain that I mentioned earlier. So we have our physically driven presentation and then our psychologically driven presentation. So what our therapeutic interventions for our physically driven presentation may look like is, let's say it's someone that's got a plantar heel pain presentation and we've identified that it's primarily come from training errors. So they've just had a sudden increase in mileage and they're just entering into that boom bust cycle. So they've done too much and then oh, that hurts, I'll stop doing something or running completely for a while. Okay, the pain's gone away, I'll go back to running stupid amounts very quickly and the pain comes back. So they're boom busting. So our therapeutic interventions, number one, it may be focusing on education. So educating them about training errors and how our tissues adapt to load and stimulus, and then also the boom bust cycle. So why doing a huge amount and then absolutely nothing, and then a huge amount, absolutely nothing, keeps this pain cycle perpetuating or the injury cycle perpetuating. So basically educating them on more sustainable training behaviours. Now, some other interventions that we may do for this individual may be load management. So with load management, it's always what I say is we need to calm things down and then build things up, which I think I pinched that from Greg Lehman. But anyway, so with the load management, we calm things down, and I always say you deload to the minimal effective dose. So for someone, if they are running 50 kilometres a week and they're in a huge amount of pain, but they can run 20 kilometres a week and they're not in any pain, that it's better to keep them moving as much as they can instead of going, just stop running. Because again, that's going to perpetuate that boom bust cycle. So having a conversation with them and being able to identify, and it may take a little bit of trial and error, 1 or 2 consults to figure out what their minimal effective dose is, but decreasing their load till symptoms stabilise, and then talking about load management as far as how we can build up their load tolerance with a sustainable running program. So just that smaller increase in weekly mileage. Now, for other people, it may be introducing just some strapping or some off-the-shelf orthoses, just short term, just to help decrease some of the strain loads on the plantar fascia whilst we're in that calm it down phase, and even maybe in the early stages of building it up. But again, that's something we're not going to discuss or argue today. It's just an example of what we may do for someone that's more physically driven in their presentation. Now, for some people that are physically driven, we may need to implement exercise therapies. So it may be some stretching of the plantar fascia, some high load strengthening on the, say, the fasciitis fighter, or it might be some plyometric exercises. Not everyone will need it. It may be purely addressing the training load errors. But if they do, anyway, these are examples of interventions that we may utilize as a clinician or implement as a clinician to address the physical load capacity equation for that individual. Now, if we're looking at psychological drivers, so that other person where it's more the psychological and or psychobehavioral elements that are feeding into their presentation of plantar heel pain, the therapeutic interventions that we may lean on and implement may be focusing on building that strong therapeutic alliance. So we're trying to build that positive relationship with the patient. We're trying to give them some reassurance and educate them and encourage them and build their self-efficacy. So it's all of those things to help try and improve their internal locus of control, help dampen down that fear-related anxiety or movement-related anxiety or kinesiophobia that they may be feeling. And tied into this is education. So we don't need to, again, this is a bit of a read the room scenario, because if you've got someone who's presenting and at that point in time, they've got a very low capacity for psychological capacity, their ability to absorb information that you're giving them, it may only be very, very small. So giving them a 1-hour talk on nociception and chronic pain may be a little bit too much for them. So that's a read the room scenario. You may need to chip away at a lot of this very slowly. But essentially the long-term goal, we may be educating them about their pathology, about the treatment options, about the efficacy of certain treatment interventions. So if someone's coming in and they're going, oh, I've heard that Barry the plumber or whoever next door, they had 3 sessions of dry needling and their heel pain was cured, I want that. So some people come in and they ask, that's not a crazy intervention, but some people come in going, I've heard someone else has had this treatment, it worked really well for them, I want that. Educating people about their presentation, what may be feeding it, what may be effective, what may not be effective, but covering all of that. Now, some of the other things that we may educate, again, it may be a bit of a slow burn and slow chip away that we do with this person. It may be educating them about pain and the somatic experience and how they can self-manage their plantar heel pain. So again, just keep in mind, we don't have to tackle all of this in the first consultation, because that's what happens with the management plan. We identify what we're going to do today to get some traction in the presentation, and then we build upon that, regardless of if it's a physical intervention or a psychological intervention. Now, for these people, we still may utilize exercise therapies, but the narrative around what we're giving the person, and then also our therapeutic goal as far as why we're giving this person exercises, may be different to someone that's more physically driven. So for someone, if it's a physically driven presentation of plantar heel pain, they may have just a decrease in tolerance or ability to store and return elastic strain energy in the plantar fascia because we've got some disorganization of the collagen that's just developed over time. So we may be prescribing high load strengthening for them to trigger adaptations of type 1 collagen to improve the tissue integrity, improve the load strain tolerance and energy storage release capacity of the plantar fascia. So we may be doing that, and that's our therapeutic goal for that person. For someone else that it's more psychologically driven, they may not have a lot of tissue disorganization or anything like that happening. There's, again, maybe more psychologically driven, but we may be giving them exercises in a low dose and safe environment to help calm their pain-related anxiety or movement-related anxiety. So it's still having a therapeutic effect, but we have an understanding as clinicians what we're trying to achieve with our exercise prescription. So for one, again, it may be building that physical capacity, but for someone else, it may be building that psychological capacity. Both are equally as important. And I think it's just always important for clinicians to be mindful of why we're actually giving an exercise and having an understanding of what we're trying to achieve from that. Because if things go right, that's perfect. But then if things go wrong, then it makes it a little bit harder if we're not actually having that critical thinking before we're implementing the intervention to troubleshoot and figure out where to go from there, if that makes sense. Anyway, so sidetracking a little bit. Now, one of the other things that we may do to help build the psychological capacity of someone that's more psychologically driven in their presentation, it may be collaborating with other treatment providers, which it may be their GP, an exercise physiologist, a physiotherapist, whoever it is. And some of the reasons we may be doing this is they may have these health practitioners that are already helping them with stress management or other issues happening in their life. And we may be able to collaborate with them to have it always has a huge impact, either positively or negatively, if you're on the same page as other treating providers. So if you have one person and say they're seeing us, podiatrists, but then they have their GP, and the two health practitioners are giving them conflicting advice, I think we all know from experience that makes it very, very difficult to get a good outcome with a patient because they've got two different things that they're hearing from two people that they know are health professionals. So they're expecting that they should know what they're talking about, but when they're saying different things, it makes it very hard for them because they're conflicted. So getting on the same page with other treating providers so we can all deliver the patients the same message can really help with overcoming some of those psychobehavioral barriers, especially if it's in relation to their positive or negative health-related behaviors and some of the modifiable psychological factors. Now, at the end of the day, it all boils down to we really just need to treat the person and not the pathology. So this is where, as I mentioned right at the start, that we want to focus on person-centered care or patient-centered care as opposed to pathology-centered care or treatment intervention-centered care, where instead of thinking that every person that comes in the door with this presentation, we have to do this specific treatment intervention or this prescripted protocol that we've come up with for the clinic, because you'll always find that there's some people it just doesn't work for. So if we take the time to sit back, get an understanding of what's actually driving the clinical presentation, that's where we get really good clinical outcomes. And if you're finding that you are dealing with these chronic and or complex presentations and you're having a little bit of frustration, hopefully today has given you a little bit of an insight into some of the things that we need to consider and how we may be able to address that. Now, if you want an extra bit of help when it comes to exercise prescription, we do have our free resource, the Movement Prescription Blueprint. So we've come up with the blueprint to help guide clinicians through the exercise prescription thought process to hopefully help you write more individualized, well-considered programs for your clients. So you can find the blueprint at progressivepodiatryproject.com/blueprint. And that's it for today. I'd love to hear your feedback about this episode. It's been great, and I'll see you next time.